All right, I have just a little bit after 6, so we will go ahead and get started. Good evening, everybody, and welcome to our joint pain webinar series. My name is Elise Hilskamp, and on behalf of Premier Health and Premier Health's orthopedic specialist, I would like to thank each of you for attending this evening. We are very, very glad to have you here with us on this very kind of rainy evening, actually. Tonight, we are here to discuss joint pain. As you may know, joint pain is a common issue for many, and you are not alone. The good news is that there are options available to help reduce your pain, increase your mobility, and get you back to the activities that you love. Our physician expert, Dr. Dennis Brown, will give a brief presentation this evening on those options. He will also answer some of your questions following his presentation. To submit a question, I want to bring your attention to the bottom of your screen. If you can kind of drag your mouse to the bottom of your Zoom screen there is a Q&A button, and that is where you can click and you can type in your question at any point in the evening this evening. We will be asking all of the questions at the end of the presentation, but feel free to submit your questions at any time, and we will just collect all of them and ask them all at the end. There's also a chat button at the bottom of your screen, but please disregard that and please use the Q&A button specifically to ask questions throughout the presentation. We will try to get to as many questions as possible tonight. Also, just so you know, this seminar will be recorded, so you will receive a link to the recording via email in the next few days should you want to go back and reference any portion of this evening's presentation. So let's start this evening off by introducing our speaker. Dr. Dennis Brown is a fellowship trained specialist in the most complex hip and knee joint reconstructions, as well as providing both non-operative and surgical care for a broad set of orthopedic conditions. He specializes and focuses his practice of both complex and mainstream total and partial joint replacement, reconstruction, and redo revisions of hip and knee replacements. Bone and joint birth defects in adults, and complex hip and knee deformities. He also specializes in early intervention techniques for hip arthritis by using advanced hip arthroscopy surgical techniques. As a result of his training and clinical experience, Dr. Brown has been consulted by colleagues, conducted and published research, and has been invited to present on these topics in both technical and patient forums. Very similar to the event that you're listening to this evening. Dr. Brown practices at Premier Orthopedics, which is one of the largest and highly trained orthopedic and sports medicine practices in Southwest Ohio. The practice offers the full range of treatment options from exercise and physical therapy to injections, pain management, and surgery where needed, including minimally invasive arthroscopic and robotic arm knee procedures. With nearly 30 doctors and more than 12 locations, Premier Orthopedics is ready where and when you need help. So thank you, Dr. Brown, for being with us this evening, and I will turn the presentation over to you.
All right, thank you very much, Elise. This is going to be a quick presentation. There's a lot to cover, and if it goes fast, you can always ask questions and we can deal with those at the end. So this is a unique start. If you look at this hip that's on the screen here, the one on your left side is a normal hip. The one on the right is dysplasia. They were born with a funny hip, and this white bone indicates that it's very irritated because it's not seated appropriately. So that's a person that doesn't have to say, I wonder if I need to have my hip replaced because this is a bad presentation. So we'll move on from here. I work mainly at Miami Valley Hospital South. We do thousands of hip and knee replacements every year and have very good outcomes as we follow very standardized care pathways. Our nurses on the floor, our scrub techs and operative room staff is excellent. They've been in place for 10 years or more. So I think that we have a good presentation on what we're able to do. And I'm going to go to my next slide. Hoping. There we go. So I'm part of the Adult Reconstructive Service. And the question still is, do you need the surgery? So mainly surgery comes in when all other forms of treatment fails. So this is a person that's 18 years old. They have the weirdest looking hips I've ever seen. They had reasonable bone depth. And you look at this and think, how can you make this person walk again? But we have really nice prostheses and instruments that allow us to do this to the person, put in a hip arthritis on both sides, and they go back to normal walking. This is another one that was born with a birth defect. It looks very ugly, but again, we're able to reconstruct this with the materials and options that we have available to ourselves. This is a knee that was born with abnormal anatomy, and again, that can also be reconstructed nowadays, which we weren't able to do 10 or 15 years ago. This is a knee that was infected. It had to be removed. It was done elsewhere. It looks terrible, like it's not really even a knee, but we were able to replace that, and I'll come back to that in a bit. I also want to start discussion with what are you going to do about your hip if that's what's bothering you. So the causes of hip arthritis are an injury. It could be while you're young and you twist and torque your hip. It can be due to overweight. It can be due to a trauma like a heavy load or jumping off something or being in a car accident. Or you can be born with something which is called femoroacetabular impingement, where the bones in the hip pinch on the tissue, causing pain. But these aren't things that you need to worry about. These aren't the most common causes, but they do appear often when people are talking about hip arthritis. So this is overuse. This is rugby, but this could be football. This could be baseball. It could be any sport. But if you do it aggressively, it really helps break down the cartilage. It breaks down the muscles and the tendons, and it leaves the hip or the knee joint somewhat unstable. This is what overweight looks like. If you look at where the pointer is, this white bone occurs when there's so much load on it that it has to keep bringing in calcium and forming thicker bone so that this does not collapse due to overweight. This is a fracture that occurs through the hip right through here. And you can see the ball is starting to move through into the pelvis. This is after all the plates have been applied and the hip bone has been reconstructed, but now you've got traumatic arthritis. There's no cartilage left. And that would definitely lead to a hip replacement. This is one that's kind of the borderline. If this ball of the hip was more in towards the center here, it would probably not be wearing out, but because it's pushing straight up into the bone, it's wearing out the cartilage. And again, this is a birth defect and it can be treated by a hip replacement. So there are things you can do to modify what kind of activities you perform. Running, I won't say is bad, but if you run on a cinder track or grass, you're going to be doing a lot less damage than if you run on concrete all the time. If you carry heavy loads with your work, if you're a construction worker or things like that, if you can reduce the loads or reduce the trips, there's less load across the hip and knee, which will protect the cartilage, which protects you from arthritis. Good shock absorbing footwear is remarkable now with how well the padding is to take load off your knee and hips. If you exercise and you strengthen the muscles around your hip and knees, that strengthening will protect the joints from further wear. So when we talk about conservative treatment, that means not surgical treatment. The things that can be done though, lose weight, exercise again and keep your muscles strong. You can take anti-inflammatory medicines such as Motrin, glucosamine, which is a good way to build up your cartilage. You can use assistive devices such as braces, canes, walkers. Modify your activities as I talked before, so you're not doing repetitive activities that break down your cartilage. And then I'm just putting in a quick plug for bone health because bone can wear down with time. If you keep your muscles strong, it keeps the bone strong. If you take in calcium and vitamin D, you'll also make sure that your bone is strong and won't wear out over time and provides good support for the joints. There's bone forming agents on people that have osteoporosis. And this just quickly shows that if you have calcium regulation in the kidneys with vitamin D and you take calcium, you're probably going to have strong bone. And these are the recommended doses of calcium a day. So vitamin D is taken up in your stomach and it goes to bring more calcium out of the stomach and into your bones. 50 to 80% of the people are vitamin D deficient, which is striking. These are the bone forming agents. And if you know anybody with osteoporosis, they've probably used one of these drugs and they do work to maintain bone strength as people age. So for surgical treatment, Hip replacements used to be about 200,000 a year in the United States. Now it's 675,000 a year. And when we talk about hip replacement, it's hip resurfacing and replacement and partial hips, which are used for fractures in the hip. This is the anatomy. It shows that there's the bone in here. This yellow is the cartilage. These are the ligaments that hold it in place. This shows the socket, and then there's a rubber gasket around it called the labrum, which helps hold it in place. So these are other causes of hip pain that you might not know about. There's hip muscle tears. The muscle is mainly on the outside of the hip and causes pain if you lean on it, or if you have fallen on the hip, you can tear those muscles and it makes your hip and leg unstable, and the pain is pretty significant and it makes it impossible to walk. Hip bursitis also occurs if you overuse your hip. And we can show some pictures and talk about that. And that's usually caused by IT band syndrome, which is a long piece of gristle that goes from your pelvis all the way down to your knee. And then back symptoms cause a lot of hip and knee pain that people perceive in the hip and knee, but it's really due to pinched nerves in your back. This is hip bursitis. This reddish tissue is what the bursa is. You hear of people that they get bursitis. It's red and it's raw because it's been getting pinched. You can see this metal piece coming in, and it's going to shave all of this red stuff out so that you're back to normal tissue, which is on the right. These are the tendons right here and right here that hold the hip in place. So this is a very easy way to take care of pain over the hip without making big incisions, and you can walk on it immediately. This is another thing, the adductor tears. When I was talking about you can have muscle tears about the hip, you can have the tendon, actually, this pointer here shows that the tendon is ripped away from the bone due to a fall. Here we're starting to repair it with sutures, and we're going to anchor it back down to the bone. Multiple anchors, but then when we get back to the side here, it's completely repaired, and within 6 to 8 weeks, they're able to walk on it and the muscles will heal back to its normal anatomy. So this is the iliotibial band I was talking about. It can rub from the hip. Here's the hip bone that you feel, and it can rub over that. It comes all the way down to the knee, and if it rubs a lot, it can cause pain over the hip here, and it can cause pain at the bottom of the knee. Either of those two conditions are painful and can usually be treated with ice or cortisone injections or physical therapy, stretching or dry needling, which therapy can work through you to fix this problem. Really, low back disease, I see as much low back disease as I see hip and knee arthritis. These orange fibers are what would be the spinal cord nerves that run down to the foot and ankle. And if it comes out to the side and runs down to the sciatic nerve and it gets pinched in these areas, where that nerve is pinched, the brain perceives that where the pain is in the foot and the leg. So back disease frequently presents as hip problems, hip pain, knee problems, and knee pain. So always think that that could be a cause of the problem, and you can see an orthopedist or a therapist to try and determine whether it's back or the joint. So we'll talk about hip replacement a little bit. There's the surgery, there's risks. The risk of any surgery is that you could have a problem afterwards. You could have bleeding, the nerve could be injured, the components don't quite fit the joint the way it was supposed to. The rehabilitation time, some people are up and walking the same day as surgery, which is pretty remarkable, and that also protects people from getting blood clots. Rehabilitation, if a person's not very strong, not very balanced, that's probably beneficial to them. We really like for everybody to go to their own home when they leave the hospital, because the hospital can still have disease and germs. And if you're in your own situation, you're probably much more likely to be able to do for yourself, which improves your recovery time. This is what's called hip resurfacing. It's a bad idea. It's metal on metal. It can cause metal ion buildup in the hip. And when that happens, it can cause irritation and breakdown of the bone. So that's a bad idea. This shows a replacement on the right that's well fixed, and the other one is the resurfacing. Again, we're trying to avoid any type of metallosis or metal debris that can cause inflammation in the hip. This is called a hip hemiarthroplasty or partial replacement. The cup here actually rotates on the ball, and this is used for hip fractures when you want to do a replacement so a person can walk, but you don't want to do such a complete repair that it takes a lot of time and there's a lot of bleeding, and recovery is longer. So this is a partial replacement. So this is a hip that has arthritis, hasn't been replaced. This is one that has been replaced. We look for these little bumps to be equal to each other, meaning we've balanced the leg lengths. We also use cemented components. Now, back in the 70s, the cement was bad. It didn't help hold up. The hip or the knee would fail within 10 years because the cement would break down. But now we found if older patients, 80 and above, have poor bone quality, that cementing a stem or cementing a knee in place actually strengthens the bone and makes it last much longer. We use it also for rheumatoid patients or low demand patients that aren't going to put a lot of stress on this. So this is what a cemented prosthesis looks like. This white is all the cement that's in the bone and fixing the cup, and then the white along this stem is all cement. And it works very well, and very, very few of these have problems. So again, this is an uncemented one where the bone has grown into the prosthesis and held it in place. This is another one on the right side where it's also grown in. So there's different ways to do it depending on the bone anatomy and what your activity level is going to be. This is a model showing the stem in an acrylic, so you can see how it would look. And the neck comes out and there's the ball, and it's located in this Teflon bearing. And then the bearing is located inside a metal shell that grows into the bone. So the beauty of where we're at now in joint replacements is there are so many devices to choose from that no matter how weird or unusual looking a hip or a knee is, there's components that have been designed for it, and we can custom fit these off the shelf to make the hip and knee replacement function at its highest level with the best stability in the long-term duration. There's also numerous different stem configurations. And these work different depending on what you're trying to accomplish, lengthening the leg, shortening the leg, increasing the strength. So there's a lot of really great options, and in our system, we have all of these available so we can do these reconstructions, maximizing their function. So this is a cup design. The metal shell up here is growing into the bone, and this fuzzy stuff is what the bone grows into. And then this is Teflon or polyethylene. It locks in. And then this shows the cup here, well polished, and then a ceramic or metal ball would fit in there and provide the stability for your hip. So when it comes to knees, what have you done for them lately? You need to take care of your knees. They provide most of the rotation and the stability going up and down stairs. And so I think this is a real positive option for you. This is showing a cortisone shot that's given to try and decrease inflammation in the knee. And the shot goes in through the skin, but it goes in this open area. This is also when we're starting to do a surgery into the knee, and it provides us a good chance to see what's going on before we do any other surgery. Knee replacements are up to 975,000 per year in the US, and they're expected to be 1.2 million in the US by 2025. So there's a lot of people with arthritis who go ahead and get these done and end up doing very well. So the anatomy of the knee, it's like a simple hinge joint. It just moves forward and backwards, but that's really not true. The knee is the most complex joint because it has both the femur bone and the tibia, which is the shin bone, and the kneecap all have to track as one to make the knee stable. And if any of the ligaments are off balance or twisted or they get damaged or torn, it makes the knee function in a very painful way, and it wears down the cartilage much sooner, leading to some type of surgical intervention. So these are the common problems with knees. There's arthritis, there's congenital or birth dysplasias that cause abnormal anatomy. Overuse or being overweight causes significant problems. And if there's been previous surgery, this really can cause a problem redoing a hip or knee. This is what I like to do, and I think we can always return people back to their starting baseline function. So this is what you don't want. This is the overuse and the overweight, and that really is one of the major problems we see currently with hip and knee pain. A startling calculation is that if you gain 5 pounds or you lose 5 pounds and you take the average, which is 2,000 steps a day, you can lose or add 10,000 cumulative pounds each day. I know that sounds ridiculous, but if you do the physics, it really does increase the load across the cartilage, and it's not made for that kind of load. This is what a partial knee is. And we do these, if you look over here on the left, bone on bone, it's worn down. You can do a whole knee replacement, which would be very good to balance it. But since this is normal and the ligaments are probably normal, we just replace the knee on the inside part. Now, these don't always last as long as a whole knee replacement because you can develop arthritis in the kneecap. And on this side, it does not address the kneecap. So usually we say these only last about 5 to 8 years. And I think that's the best option for minimal arthritis. This is before surgery here, which is where, again, there's bone touching bone. And this is what the replacement looks like with normal joint space and the knee is straight. And this is what the components look like. So the component metal is cemented to the bone. Then this insert, which is the Teflon, fits in there. And then the metal piece is cemented on and the kneecap tracks normally. So this is the ideal. This is what we want every knee replacement to look like. And with the current alignment instruments we have in the robotic arms, we can really reproduce this almost every time we do a replacement. So a lot of people ask, how long is the recovery? Well, if you look at the pictures, the pink means doing household chores. Takes about 3 to 6 weeks to get back to doing those. 4 to 6 is when can you resume sex, which should be 4 to 6 weeks. And then the green is you're checking into work at 6 to 8 weeks, or you're swimming, or you're walking in the pool, or you're able to drive appropriately and independently. So those are usually the guidelines when we're telling patients how they'll recover. These are the usual landmarks when you're back to functioning at a normal level. So again, here is the recovery phase. You can spend a minute here looking at it and figuring out how this would go at your pace to recover if you have joint replacements. One thing is about driving. If you have your left knee or your right knee operated on, or your right hip, you're considered an impaired driver in the state of Ohio, because you have to be able to go from your foot on the brake to covering your brake pedal in only 0.2 of a second, which is really fast. And if you can't cover that and you're in an accident and there's skid marks that say you didn't brake quickly enough, you would be considered an impaired driver, even though it's due to the fact that you've had knee or hip surgery. After 2 weeks, if you're not on pain medicine, and only if the left knee was replaced, you can drive easily within 2 weeks. So this is the difference between why we would do a uni or a half knee replacement versus a full knee replacement. So if we look here on the left, you can see the cartilage is worn out in numerous places. It's destroyed. There's no just one side that you would replace. So this would become a half or a full knee replacement like this. And then this one shows the outside compartment's completely normal, but the cartilage only here is worn out, and that's where we would do this half knee replacement. So that's the difference between a whole knee replacement and a half, and what makes us go along those lines. So I've gone through this very quickly because I want to have some time to talk with you about your questions. So I think that if you're ready to start putting those in, we can talk about these items and maybe give you some fine points that would allow you to decide what your next procedure or what your next plan is if you're having joint problems. So I personally thank you for attending. And Elise, are we getting any questions that we can talk about?
We do, and I'll just, before I start, I want to remind everybody again, if you do have questions to ask Dr. Brown, scroll your arrow down to the bottom of your Zoom screen. You will see a Q&A button. You'll see mute and things like that. Hit the Q&A button and go ahead and type it in and submit. We have our first question here. Are you more prone to infections with a replaced joint?
That's a good question, because that's most people's greatest fear. It would be my fear if it was my own joint. The reason that you can get infections in joint replacements is The surgery causes a lot of scar in the area, which you want it to be so that it's a nice stable joint, but it also makes the circulation of blood in the area a little more tortuous. So the blood tends to slow down as it gets in that area. And if there happens to be any bacteria in your blood, it will slow down there too. And if it slows down enough, the bacteria sets up shop in that area. So that is a problem. Blood-borne infection can ruin your joints. It can cause them to become loose. They become painful. The bone breaks down. So getting an infection is probably disastrous in your hip and your knee. But fortunately, there's a lot of literature on what you can do to protect against it. So if you have dental problems, if you have loose or cracked teeth, or you have a lot of cavities, that's a good source of infection to your hip and knee. So you would like to get that taken care of before you would have these joints replaced. Or if you have injury to them and you have joints already in position, you would want to make sure that you take care of the teeth and make sure that you take antibiotics to protect against that. Another thing is, if there's been surgery on it before, sometimes bacteria gets left behind, and maybe the knee or hip is working well, but at 5 to 7 years, they start having pain and swelling, and it turns out to be infected. And as I showed you earlier, there were some pictures of the knee which didn't even look like a knee because we had to remove the components, and it was bone rubbing on bone, and that's how you would go about curing an infection. So while an infection is worrisome, our rate at South is not even 1% infection. So you've got a 99% chance probably that you would have no problem with infection. And especially if you take care of your joints, if you've got diabetes, that it's under control. If you don't smoke, smoking increases your risk of getting a joint infection within a year to 5 to 10%. I hope that answers your first initial question.
We have two questions that are kind of similar, so I'm going to kind of combine them. It says, given our family life spans well into the 100s, how long should we put off getting a replacement? How long do they last? And the next question right below that is specifically asking about how long does the average total knee replacement last?
So the joint replacements didn't occur until 1960. That's when the first hips, and they were cemented, came out. And it was amazing how they would reduce pain, but the cement that was used in it was of very poor quality. And so they would last maybe 8 to 10 years, and people would be happy with 8 to 10 years of pain relief. But having to repair it or redo it and remove that, it's a big deal to do revisions. And so right now, the cement, if we use cement, lasts a good 20 to almost 30 years because it's a different quality. We also put in uncemented joints where your own bone grows into it, and that usually doesn't become the loosening component. Where we have problems is if the Teflon bearings are overloaded and they begin to break down. That can also lead to replacement. But right now in the labs, because all the different companies that make these components have them running in laboratory simulations of load. So these go through these repetitive loading cycles, 30,000, 40,000, 100,000 cycles a year. And then they tracked how much load and how much damage has been done to the knee. At 100,000 cycles a year, that's probably 35 to 40 years of use, and yet they're not showing wear debris or loosening at that time frame. So I'm not that concerned about the age when it's put in, because let's face it, a 100-year-old or 95-year-old's not going to be running on concrete, jumping down stairs, things like that. So they're not going to wear it out. So it would last them their lifetime. If you're talking about a person that wants to have their joint in and wants to go back to skiing and running super marathons, that may cause wear. But again, at 1,000 cycles in a year, that probably still isn't going to wear it out. Personally, I've had both my knees replaced, and I still play tennis and I go skiing, and I really don't worry about wearing them out. I don't think you should either.
Okay, our next question is, can you do total knee replacements arthroscopically?
No, because you've seen the size of the components. They're not tiny to get in. Now, there are people that will cement little pieces of metal on Teflon into the knee, and they make a very tiny little scar, but it doesn't have enough bone surface to grow into. So those do fail prematurely. So the length of the scar isn't the problem. The scar heals from side to side, not end to end. So it doesn't matter how long it is. You just want it to heal. And if you've closed it appropriately and there's a good blood supply, it doesn't really matter. I mean, if you make really long incisions, the ends of them can be a little painful or a little touchy for a short period of time. But I really would not encourage anybody to worry about the length of the incision, because it really doesn't make a difference in how the knee works stability-wise, how it defeats any kind of infection or inflammation. And except for the scar might be looking bad, most of them within a year are almost imperceivable. You don't even notice them.
Our next question is, how do you determine who is a candidate for robotic joint replacement versus non-robotic?
The literature on it does not say that the robots are any more efficient and accurate and make the joints last longer. They're expensive, but the beauty of them with the robot is that it allows more precise alignment and cutting jigs, so that when you do make a cut, you've checked it 3 or 4 times, or the computer has checked it for you. Now, the computer doesn't make cuts, and the computer doesn't align itself. We make a plan for it and then enter this into the robotic computer. And then when it's time to do the surgery, it places these cutting jigs in exactly the place that we want them to be. So there's no real variability. But like I said, there's nothing that says they're better than a good surgeon who's been doing it for 20 or 30 years. I think that going forward, you're going to see more of this happening. But I also think that the standard techniques and balancing are going to be beneficial. Right now, there's only one system, robotic system, that really is used for hip surgery. And they have that at our North Hospital. And that can be a good way to look at other robotic and computer assisted surgical means to get the best features. But until we have literature that says in this study of 1,000 people, they actually did 4% better than people that didn't have the robot. There is no study that says that. So when people say, oh, I'm going to have the robot because it's so much better, you do have to put a couple drill pins into the knee or in the lower leg and the upper leg, and those make computer arrays, and they tell the computer where the knee is in space. So if you have soft or brittle bone, you're not a candidate for one of the robotic treatments. But if you have deformities in the knee and those need to be correct and the computer needs to register the correction, putting these arrays in, if your bone is strong, is a very good way to ensure that you're going to have a good result. But poor bone quality or significant birth defects or trauma with abnormalities, that's probably not better for the computer or for the surgeon doing the surgery themselves. But I think we're heading on the way where this is going to be the de facto standard within 5 to 10 years.
Our next question is, I can't take any pain meds. I can get through a replacement, or I'm sorry, can I get through a replacement without any? I have had 2 rotator cuff repairs without meds, if that is at all comparable.
Yeah, rotator cuffs are just as painful as knees are. Yeah, the new guidelines, I mean, in the state of Ohio for using opioids, they've really cut down on how much you need, because you don't. So when we do a knee or hip surgery, we put long-acting blocking anesthesia in and around the knee, in the thigh, and around the hip. So you probably get close to 4 days of pain-free after a hip or knee surgery. And most of those people do well with taking extra strength Tylenol, 3 grams of it a day, and that's not going to cause liver failure. We also put numbing medicine in. We put in steroids. We put in long-acting anti-inflammatory medicines. And these can last a long time, not requiring opioids. And the problem with opioids is the body builds up a tolerance even after 3 or 4 tablets, and it makes it difficult to stop. We also use muscle relaxers, and they are very beneficial because the muscles have been insulted when you do a surgery and you open it up, and they go into spasms. So we also treat with muscle relaxation, which is not an opioid drug. So I think our pathways are very clear that yes, you can have your surgery, and you did have it with your rotator cuff, and you're able to get through without opioids. And that's our plan for pretty much every patient.
I have one final question, so I'll make this our last call if anybody else has additional questions. Should I have both of my knees replaced at the same time?
And that's a great question too, because there's dilemma on, is it better to do both or is it better to do one at a time? If you're very healthy and you're not overweight, and if you have diabetes, it's perfectly controlled, you would probably be a good candidate to have both done. But you have to realize that it takes a lot of protein in your body to heal an injury, and any joint replacement is an injury. So the thing is, if you are a good candidate to have both, it's a struggle because you don't have a good leg to stand on. You have two moderately good legs to stand on. And so getting them both done is nice because when it's over, you don't have to come back. You're not looking for having the other knee done at a later time or the hip done at a later time. So I think if you're healthy, your bone quality is good, your motivation is good, and you're really going to participate in the therapy and the exercises, I would do that. But I probably only do 5 to 7 of these a year. I think that most people are only asking for one at a time because they're not equally as bad on both sides. But it is a good concept, and I'm glad you brought that up so people can hear that it's not a bad thing and it can be done. It just takes a little more time to get over it, but not having to come back for surgery is a real positive.
Okay, I have no further questions in our Q&A box, so I think that we will wrap this up then. So thank you, Dr. Brown, for your informative presentation. We very much appreciate your time and expertise. And I want to thank all of you so much for joining us this evening. I hope that you have found the information shared useful. We feel very privileged to be with you tonight and hope that you consider us for any healthcare needs you may have. If you would like to learn more about Dr. Brown or his practice, Premier Orthopedics, you can visit premierorthooh.com. More information about Dr. Brown can also be found on his bio that was sent along with the information to access tonight's event. Should you have additional questions or would like to make an appointment, his office number is on both the practice website and on his bio. Last but not least, as a reminder, this seminar was recorded and we will email you a link to the recording should you want to go back and listen to some or all of this great content again. And as soon as it is available, we will share the link to access the recording via the email that you received the link for this evening. Along with that link, we will also share a short survey link for tonight's program. So we value your feedback and we would appreciate it if you could take a few minutes to share your thoughts with us as well. So with that, we wish you all a very good evening and thank you again.
Yeah, I thank you for your time too, because this is important. And I really am surprised. These questions are excellent. And I was trying to get through the lecture quickly because I wanted to leave time for the questions. And I think they've hit very good questions and hope this is what they were looking for. And I'd be happy to do this again. So thank you, Elise.
Thank you, Dr. Brown. Have a good
All right,
evening,
good
everyone.
night.